Hello everyone, I'm Huda Ezzeddin, a consultant in diabetes and endocrinology, and I'm here with you on the 16th edition of the EDEC Congress, and I'm so pleased to introduce my colleague, Dr. Khadija.
Hi everyone, my name is Dr. Khadija Hafidh and I'm a consultant diabetologist based in Dubai, and it's a great pleasure to be at the EDEC conference.
Fantastic. Dr. Khadija, we would like to talk about the screening of diabetes. And I was so impressed to see how it's going on with the introduction of the screening guidelines. Can you just brief us about what's new this time about screening for type 2 diabetes?
So we've had quite a number of rounds of deliberation around the screening, and for our particular context in the United Arab Emirates, because of our population dynamics, the thing that we want to emphasize this time is that the age of screening needs to be, the cutoff is lower, it's 30 years of age. We would like that we adopt these screening strategies very early on, and we would also like to make sure that those individuals who are at risk for developing diabetes, who have other sort of conditions that may be putting them at risk, are identified and picked up early, not just in the tertiary care centers, but also in primary health care centers.
Absolutely. Can you just prioritize what are the categories of people that we really need to focus on to screen?
Right. Yeah. So we would like to make sure that those individuals who have a family history, so a first-degree relative who has diabetes, should be offered screening. Individuals who are living with obesity or who are overweight, individuals who have other conditions, comorbid conditions such as hypertension, dyslipidemia, should also offered screening or evidence of the metabolic syndrome. We'd also like to include women who've had gestational diabetes or have had history of a large baby. More than 4 kilograms would qualify for that. We'd also like to consider certain individuals of high ethnic groups that we know have a higher prevalence of diabetes, and that would include people of Asian ancestry, for instance. And then we'd also like to include individuals who are on certain types of medications, glucocorticoids, diuretics, antipsychotics. They should also be included in the screening program.
I mean, it sounds like the whole of the population. So, are we doing universal screening?
So
in a way,
we wouldn't really call it universal screening, but we want to get to a point where perhaps we can offer universal screening. So far we've put in the guidelines at least the age at which we should start thinking about it. We've also highlighted certain groups of individuals who we think that are high risk that I've already mentioned. And it's important actually that we do that because we do have a very high burden. Even when the IDF Atlas updated their Atlas a year ago, we see that we're still quite high in terms of our prevalence of diabetes. And therefore we know that if we can screen and identify people early, we can put in the necessary interventions so that we can prevent people from having the complications. So in a cost effectiveness sort of perspective, it makes much better sense to try and get people early on, offer them treatment, or just, so that they're aware of the lifestyle interventions that can be offered, so that we're not overburdened with treating complications of diabetes.
Yeah. So when we talk about screening, and in other words, we're preventing ahead of time the development of diabetes, but then what about practical implementation of these guidelines? How are we getting on with it?
Right, and that's so important. You bring up a really important point about the implementation. It's not just enough for us to have a paper, that sits in someone's desk, but the implementation will really need to be done at all levels, at the grassroots levels as well, so at primary care centers. We should be able to involve not just the physicians, but perhaps allied healthcare providers as well. Maybe we need to incorporate it into our electronic health records so that it flags out, this individual has obesity, this individual has hypertension, has a screening for diabetes been done. We're even recommending now that opportunistic screening happen in the dental clinics, because we know individuals with periodontal disease also have a higher risk for dysglycemia, and the presence of dysglycemia makes periodontal disease much more difficult to manage. So we've identified that there are certain areas where screening can happen, and it can happen sort of automatically. We can automate it. Apart from that, we might be thinking about having outreach programs, campaigns where we can go out into the public, and this requires a lot of effort and resources, but it's also something that's, doable.
Yeah. I mean, even in my practice, I find that quite often we find a bit of resistance and some barriers to screen. How do you go around that? If
right.
a patient
Yeah.
doesn't really feel comfortable.
That's absolutely right. We have a lot of barriers, and I think the biggest barrier is the fact that it's an asymptomatic condition. Most individuals don't have any symptoms at all, and perhaps we need to kind of increase their awareness about the consequences of having a late diagnosis versus knowing something early. Of course, that would also mean that we would have to have the screening with proper counseling, so that it's not just that I do a blood test, but if we try and explain to them as well what are the consequences, what are the things that they can actually do to help themselves, help their families, in order to avoid having the complications of a late diagnosis of diabetes.
Yeah. Some patients, they do ask me, so should I come fasting or should I be random, come at any time? Because we don't want fasting becomes a barrier for screening.
Yeah.
So tell me about the readiness.
Okay. So there are various ways in which we can do the test. Of course, fasting would be ideal to get a fasting sample. Short of that, we have the hemoglobin A1C. We could use that as well as a screening method. However, there are certain caveats that we need to look at, because we are in a region where there's a lot of hemoglobinopathies, so that might also affect the hemoglobin A1C readings. And so it might be important actually to do both tests, the fasting and the hemoglobin A1C. A random sort of glucose reading in of itself cannot be used unless you have somebody who's already symptomatic. So in the presence of osmotic symptoms, the person has polyuria, polydipsia, and so on, a high random blood glucose would be suggestive of diabetes, but we don't recommend that be used on its own. It should be used in a more sort of structured way, where you have the oral glucose tolerance test. A defined amount of glucose is sort of given, and then the tests are done thereafter. So these are the sort of a bit of the practicalities, but it is easy to get around those also.
Yeah. Dr. Khadija, sometimes we get those patients who are in the middle, so their fasting blood sugar is not absolutely normal and it's not really diabetic range. And how important is the pre-diabetes?
Right, you're absolutely right. And we saw in the figures that were presented today as well, around 11.8% diabetes and 11.8% pre-diabetes. And we recognize that this is a category of people who are also at risk for cardiovascular diseases. It's not uncommon in the coronary care unit to see somebody coming in for the first time with a myocardial infarction and when you do the test, they have prediabetes. So this is another category of patients that we need to concentrate on. One would say it's the smoke before the fire, and therefore when we do identify them, we should put in the necessary interventions, whether they are lifestyle or non-pharmacological and pharmacological, in order to prevent them from progressing into the frank diabetes.
Do you think community engagement with those lifestyle awareness campaigns would help in identifying patients at risk, or is just being done for fun? How do you see,
it's
marathons?
It's always challenging to get people to change behavior, because it is about changing behavior. You might be used to a certain way of eating, we tend to be more sedentary, especially the older that we get, and people are busy with work schedules. You work 9 to 5, and then when do I put in the activity? But what I try to advise my patients is that try and incorporate the activity within your work schedule. So while you're taking your break, for instance, rather than use the elevator, why not use the stairs? And that would give you your step count. Before you go home, why not walk around the block or something? So there would be minor sort of things that need to be done. One doesn't necessarily have to go to the gym and get membership and pump iron and things like that. So simple things. When you're going to the mall, park your car as farthest away from the entrance so that you get a little bit of walking as well. And I say try and avoid the food court if you can. So there are sort of minor tricks and things that people can do to make physical activity as part of their daily routine without it being an extra burden on their lives.
Yes, so I think this is quite important, that we don't want to engage people with physical activity indirectly without knowing that they're actually doing it.
That's right.
And then adopt healthier lifestyle and healthier diet, and not necessarily focus on weight reduction, because that's one part of it, but not the whole thing. Don't you agree that?
Correct. Yeah, that is absolutely right. And we're quite fortunate actually in the UAE in that our Crown Prince, Sheikh Hamdan, is very motivated, is a very sporty individual, and he inspires us every November to do the 30-day fitness challenge. And I think that gets a lot of people motivated. You see, even people who've never cycled in their lives try cycling, and we also, the government has tried to put in an infrastructure to allow people to exercise for free. So if you go to the parks, for instance, the general parks, they have open air gyms, as it were. They have the equipment which is there for everybody to use, and you don't have to pay anything for it. Which is really great as an initiative.
We're quite fortunate to have these.
Very fortunate. Yeah.
True. Thank you so much, Dr. Khadija. If there's one thing that you would like to inform the audience as a final recommendation
so I
or
think
advice.
The one thing that I would like to emphasize, especially for our primary care colleagues, is that to try and seek those opportunities to do the screening for people, to look and identify for the people who might be at risk for diabetes as early as possible, so that the burden of care at the tertiary level is much less. Right? If we pick them up early and we can do the interventions at a primary level, we need to spend a lot less later on.
Great.
It was lovely talking to you. Thank you so much for having me.
Thank you so much. Can't thank you enough.
Right. Good. Yeah, it was long.